Well, the theme of this afternoon is partnering with patients, and I'm going to be talking, echoing really how important that is and how important talking to patients is, but with particular regard to female and genderqueer patients who continue to face very particular challenges and obstacles to getting the care that they need. My focus is going to be on women, but when talking about research and funding, I'm usually talking about people with female biology, while in cases where I talk about care and the way we respond to women, I'm usually talking about all people who identify as women. So I wrote a book off the back of my PhD in the sociology of medicine, here it is, about the gendered ideas in medicine that reflect and reinforce those that exist in culture at large. And the takeaway message is that researchers, clinicians, and medical practitioners are all members of that self-same culture and are all subject to the same biases and assumptions that the rest of us are. I argue that this is unavoidable, and it's something we need to take responsibility for to do right by our patients. So I'm going to take a bit of a broader look at the culture in medicine and how we create that culture. I opened the book with this image, which went viral in 2019. Thousands of Twitter users were really amazed by the floral shape of the milk ducts that were totally absent from the textbook images of skeletal, nervous, and muscular systems they'd come across in their training or at school. Those rarely had breasts and usually had the square shoulders more typical of males. In the case that female anatomy was at issue, perhaps they would have been presented with the same male body, only now differentiated by a female reproductive system. In short, they would have been presented with a bikini vision of biology, the idea that everything beyond the reproductive organs is the same across genders, that medicine is gender neutral. There was much dispute about the milk ducts, which, it was argued by many, are not strictly part of the muscular system. But that depends on what we're trying to represent. From a female biology perspective, it makes sense to include milk ducts in these diagrams due to the role they play in tissue stimulation, in releasing oxytocin, activating mammary muscles to eject milk. Images are hypotheses about how the body works, and many of these continue to reflect questions about male rather than female anatomy. So my book is a book about assumptions and about how we deal with them. We assume that medical knowledge is gender neutral, and we need to assume the opposite, because we're failing to meet women's needs. And here comes that quite well-known statistic that although women on average live longer than men, they spend more of their life in poor health, limiting their ability to work and participate in society, which in turn obviously reinforces other social inequalities. So there's a growing awareness around this issue, but we easily overestimate the progress we've made. Just last year, there was a BMJ study showing that UK doctors tend to overestimate the progress we've made towards gender equality in the profession in UK medicine. It also showed that a person's tendency to overestimate progress is linked to a greater reluctance, particularly among male doctors, to back initiatives that promote gender equality in the profession. These assumptions don't just breed complacency, they can, of course, be fatal to patients. Male-centric medicine is reinforced by an incomplete knowledge base, and this becomes a self-sustaining spiral where assumptions about gender neutrality block research, and the absence of research reaffirms these misconceptions. Women's bodies continue to be treated as marginal in research, just as in textbooks. I spoke to quite a few researchers while researching for this book who noted the discrepancies in funding going to women-specific areas, and who also noted how members of boards are less interested in what are perceived to be less cutting-edge areas when it comes to funding. In the book, I give this example about a US-based bioengineer called Linda Griffith, and she founded the MIT Center for Gynepathology Research in 2009 with the goal of helping researchers solve endometriosis. And she talked to me about the funding issues she faced with the disease, which is still often dismissed as benign, as non-cancerous, but as we all know, still life-inhibiting. Her mission then is not only to try to cure endometriosis, but to change the conversation from one of women's pain to one of biomarkers, genetics, molecular networks. Working with models of uterus organoids made from uterine cells of endometriosis patients, her work draws on the uterus as a window onto tissue regeneration, scarless wound healing, and immune function. It is work that matters to us all, not just to women. I don't want to make endometriosis a women's issue, she told me. I want to make it an MIT issue. The work that Griffith has done, or has had to do in rebranding her lab to get funding, is testament to how far we have to go to build a truly gender-neutral medical culture. Bikini vision biology means we're missing important opportunities to advance medical research in the interest of all patients. These issues continue to be silenced, or issues around women's biology continue to be silenced at the level of funding research and also, however, unconsciously among practitioners. There are now numerous studies by now showing that women who report acute pain are less likely than men to be given opioid painkillers, and once prescribed, wait longer to receive them. How women wait longer in A&E and are classified as less crucial. Just last week, or 2 weeks ago, there were reports at St. George's Trust that they've been routinely downgrading 3rd and 4th degree tears from moderate harm to low or no harm. And we know that these are life-changing injuries for women. These are systemic issues and products of a culture and history that treats the male as default. Practitioners can only do so much to oppose the force of that existing system, but we have to situate this problem in medicine in a sexist culture, and we have to take responsibility for that culture. I've heard this being said about racism, that as with COVID during the pandemic, we have to assume that we have it, and the same is true for sexism. We have to assume that we have sexism. We've been socialized to treat the male as default. It doesn't define us, but we need to take responsibility. And so it's crucial that we ask what assumptions lead us to disregard certain problems, what social cues we give women about what is normal and what is expected. How can we expect women to report their problems and make use of health services when we're not receptive to their needs? This is work we have to do so that they don't have to. A good example, I think, of the kind of improvements that can come from talking to women, from listening to women, is the recent Uscreen trial where they sent cervical swabs, screening swabs to women's homes. So, as you probably know, cervical screening has the potential to prevent 70% of cervical cancer deaths, but a third of women don't attend their screenings. And studies were done into the reasons why, showing that embarrassment is often a key hurdle to women not attending their appointments, as well as cultural barriers or fear about what this procedure might involve. So in 2021, the NHS and King's College London launched this trial where they sent at-home testing kits to 31,000 women, so that they could do the test in the privacy of their own homes. So I think this is a great example of the kind of simple intervention that can come from responding to women's needs that they are aware of, that they can articulate themselves. All it takes is listening. So putting women at the center of medicine alongside men will require an ongoing process of self-reflection and response. And this is a culture of accountability we have to actively cultivate. And one of the ways of doing that is by being open about the challenges we face, by continuing to have an open conversation. So I'd love to hear from you in the Q&A today what your experience has been when it comes to delivering gender-sensitive care. What dilemmas have you faced? What encounters or thoughts come to mind? And how you evaluate the schemes that do currently exist. What aha moments have you had? What have you missed? And what support is lacking and what would help? I'd love to hear your views. This is a really good opportunity for me as well. So thanks so much. And I think we're going on to the Q&A.